Hi, everyone. Welcome and thank you for joining today. My name is Sarah Ridenauer, and I'm excited to be here for another Facebook Live during Heart Month. Today, I'm pleased to be joined by four of our experienced advanced heart failure specialists from MedStar Heart and Vascular Institute, Dr. Sheikh, Dr. Vora, Dr. Afari, and Dr. Kadakkal, who will help us understand what heart failure is, as well as a condition that is often misdiagnosed, progressively gets worse if undiagnosed, and could be why heart failure symptoms are not improving for some patients. So give us a like to let us know you're watching. As a reminder, if you have questions throughout the session, please be sure to drop those in the comments below and we will get to as many as we can. Before we get into our questions though, let's get to know a little bit about our providers. I'll start with you, Dr. Sheikh, if you could introduce yourself.
Good afternoon. My name is Farooq Sheikh. I am the medical director of the Advanced Heart Failure Program in the DC region.
Great. Thank you. Dr. Vora.
Hi, I'm Tania Vora. I'm one of the heart failure cardiologists at MedStar Washington Hospital Center and Georgetown.
Thank you. Dr. Afari.
Good afternoon. Nana Afari. I'm one of the advanced heart failure cardiologists here at Washington Hospital Center.
Thank you. And Dr. Kadakkal.
Thank you for having me. Ajay Kadakkal, one of the other advanced heart failure cardiologists at MedStar.
Great. Thank you again for joining us today. And let's get into the questions. So I'll start, Dr. Sheikh. What is heart failure? And, what are the different types of heart failure?
Thank you very much. So a term that we ourselves did not invent. We want success rather than failure, but a term that has been in the field of cardiovascular medicine for a number of decades. Heart failure refers to a syndrome by which individuals who suffer from this disorder feel symptoms that limit their exercise capacity and their quality of life. To simplify it, it would be that there is a constellation of symptoms that result from the incapacity of the heart to perform its normal function. And we're going to talk about that in a few minutes as to what those symptoms are, but I'll just mention a couple: shortness of breath, fatigue, swelling in the lower extremities and in the abdomen. And there are hundreds of causes of heart failure. We have a very sort of elegant diagnostic scheme and criteria by which we define this, which affects how we treat the disease. And it's a field that we've gained tremendous knowledge over the past 50 years about.
Okay. And what is the difference between heart failure and advanced heart failure?
So nearly 7 million Americans suffer from heart failure, but there are those patients, a smaller percentage, some estimates as 10% of those 7 million, maybe less, where despite implementation of guideline expert medications that have been defined by experts to be life-saving, to improve the quality of lives of our patients, to improve the functional capacity, patients remain very limited. They still suffer from symptoms of breathlessness. They can't stay out of a hospital because the symptoms are so bad that they require immediate medical attention. And that is the disease state of advanced heart failure, a disease where beyond medical therapies, we must consider other therapies, most notably cardiac transplantation and left ventricular assist device therapy for that population of patients.
Okay, thank you for explaining that. And you had mentioned some of the symptoms, but Dr. Vora, what are the most common symptoms of heart failure and some others that Dr. Sheikh didn't mention?
So the symptoms of heart failure do depend on the stage of heart failure that a patient may be in. Early on, and a lot of the main ones that people think about are shortness of breath, trouble with fluid management. So you may find a lot of swelling in the legs, swelling in the abdominal area. Other things like coughing, sometimes also we can see as the fluid builds up in patients' lungs. At night, it can be difficult to lay down flat because the fluid is coming up. And then as heart failure progresses, we sometimes see more symptoms like fatigue, difficulty concentrating, decreased appetite, early satiety, feeling full as soon as you start eating.
And my next question is, are there any symptoms that are often overlooked? You naming those, I can think of a couple that I might overlook.
So I think a lot of especially things like a cough may initially be overlooked or be attributed to something else like asthma. A lot of times patients who have even shortness of breath will get diagnosed as pneumonia. So those can be missed. And then definitely the abdominal symptoms. Anyone who has heart failure and has abdominal symptoms like nausea, vomiting, or what we talked about before, decreased appetite. Even cardiologists may mistake those as coming from the abdomen, but if you have heart failure, that definitely could be coming from the heart as well.
Okay. And who is at risk for heart failure?
So, like Dr. Sheikh mentioned, there is a slew of different causes of heart failure. And so that does unfortunately put a lot of people at risk for heart failure. Certain medical conditions, such as high blood pressure, blockages in the heart, diabetes, obesity, can put you at risk for developing heart failure. And then there are medications that cancer patients have to get, for example, that unfortunately are also toxic or can be toxic to the heart. There can be other substances that patients use a little too much of, like alcohol, or if you use illegal drugs such as cocaine or methamphetamine, that can put you at risk. And then genetics. If you have a family history of heart disease, that certainly can put you at risk for developing heart failure.
Is there a certain age range that, is more at risk for it, or does it can affect anybody?
So unfortunately, this is one of those diseases that doesn't discriminate. So we have patients who are very young who present with heart failure, even as young as their 20s, especially if it's a genetic cause, and then patients who present much later in life. So it really does span the age range.
Okay. And Dr. K, how is it diagnosed? Are there specific tests? What do doctors look for to get that diagnosis?
Well, there are a variety of tests that can be useful to determining not only the cause, but also just coming to a diagnosis of heart failure, whether it be low heart function or even a stiff heart or restrictive heart function. When you have some of those symptoms that Dr. Vora had mentioned, most doctors, whether you're a primary care doctor or your initial assessment with a cardiologist, will likely start with, in addition to your physical examination, EKG, looking at your heart rate, looking at your heart rhythm, any abnormalities that can give us a sign of whether or not we should be worried about, as Dr. Vora mentioned, blockages in the coronary arteries, a history of heart attack, any electrical system abnormalities that may guide us during a diagnostic pathway to look for other infiltrative diseases such as amyloid, which we'll talk about later. In addition to your EKG, blood work can be very helpful, checking your kidney function, your electrolytes, certain cardiac enzymes that can be elevated in a variety of heart conditions that can result in heart failure. And probably the one gatekeeping test that often allows people to be referred to a heart failure specialist, most cardiologists will do in their office, would be cardiac imaging with an echocardiogram. Easy to do in the office, cost effective, can get beautiful images, an ultrasound of the heart to really get a lot of information looking at heart structures, what the heart muscle looks like, how well it squeezes, how well it relaxes, and that can guide us as far as what would be appropriate further testing to determine the cause of the heart failure.
Okay. And you had mentioned primary care. If you start, going through this with your primary care doctor, at what point would a patient then be referred to a heart failure specialist?
So I think if there's any abnormality worrisome of either low heart function on an echocardiogram or stiffer heart function, or even if you're having symptoms that are refractory to what we think would be normal treatment, right? They're following with your primary care doctor and you're still having persistence of those symptoms that Dr. Vora had mentioned, despite your blood pressure being controlled or despite diuretics or other medications that have been recommended to help manage your symptoms. If you're not getting better, that should prompt a referral to a heart failure specialist. And even with any of this diagnostic testing, we welcome earlier assessment whenever there's been a diagnosis for the very reason that the causes for this heart dysfunction or any type of heart issues can be varied. And with that variation, there can be a lot of variability as far as prognosis, treatment options, and someone's clinical course.
Okay. And speaking of treatment options, what are the treatment options available for those diagnosed with heart failure?
So again, it can vary in what we think the underlying cause is.
Right.
When we do see someone diagnosed with heart failure, in particular with what we call a reduced ejection fraction, or the heart squeeze being low, as I like to say, there are standard regimen medications that we really try that's been shown to really provide a mortality or a survival benefit. So these are heart medicines that a lot of people may be familiar with, blood pressure medications like lisinopril and Entresto, heart medications that can slow your heart rate down like beta blockers like metoprolol. Diuretics can help manage fluid retention, diuretics like Lasix, spironolactone. And often we've learned medications that we've previously been using for diabetes have been very beneficial in heart failure and reducing hospitalization, improving heart function, and improving survival. Those medications that you may see plenty of commercials like Jardiance or Farxiga, some what we call SGLT2 inhibitors. And so these four classes of medications are usually our go-to and standard therapy when it comes to your, if you will, run-of-the-mill low heart function. Now, there can be other causes for heart failure that, again, allow us to tailor our therapy, whether someone has an inflammatory condition that will require immunosuppression or infiltrative diseases that require other disease-modifying therapy in addition to those medications to help preserve heart function.
Okay, thank you for going over that. Um, Dr. Afari, are there any lifestyle changes that need to be made after a diagnosis in addition to the treatments?
Thank you. So there's certainly a few lifestyle changes that are recommended, especially after a diagnosis of heart failure. The way I typically like to think about it is, the goal of this is to help reduce those heart failure symptoms that you've heard just previously. So the first thing I usually tell my patients is importance of limiting your fluid intake, right? So especially as you progress into the more advanced heart failure, excessive fluid intake, if you drink too much fluid, can lead to all this swelling in the legs, the shortness of breath, the difficulty sleeping at night because of a hard time breathing, as Dr. Vora mentioned before. So ideally, we tell our patients to limit their fluid intake to under 2 liters a day, which is equivalent to under 64 ounces a day. It's hard, and I tell my patients this. No, you'll find it challenging, but it's certainly one of the best changes you can do. Secondly, and while there's still a lot of debate about this, I think it's certainly important to monitor the sodium or salt intake early. It's the ideal, or what we recommend for patients is you limit your daily sodium intake to about 2,000 milligrams a day. And you ask yourself, what does that mean, right? It's always hard to quantify that. So imagine just, taking a teaspoon of sodium a day or salt a day. That is hard, right?
Wow, yeah.
Especially since there's salt in everything that we're eating. So what I usually tell my patients is the first thing you can do is if you put extra salt in foods, stop doing that, right? If you're eating canned foods, frozen foods, processed foods, cut those out. So things like deli meats, fast food. If you can cut those out, those are a great start. We all know wherever sodium goes, salt goes, that's where fluid goes as well. So it's a way to manage that also. Another thing you can do is weigh yourself daily. So sometimes you don't always develop those leg swelling or the shortness of breath unless you're more in the advanced stage of symptoms. But sometimes with a weight change, let's say of more than 3 pounds a day or more than 5 pounds in a week, that's a good way to catch on to the fact that you're picking up fluid and maybe call your doctor at that time. Right? And of course, it's, as a cardiologist, it's certainly important that you remain active, right? So walk-in, light exercises, those are really great ways. And Dr. Vora also mentioned making some lifestyle changes such as decreasing your alcohol use, right? So not drinking too much alcohol, and of course, avoiding cigarette smoking and illicit drug use. So those are really good ways, lifestyle changes you can make after diagnosis of that.
Okay. Yeah, I'd have a hard time with the salt thing. I love
Yeah.
my salty foods,
Right.
salty seasonings. I'd struggle with that.
Yeah.
And can heart failure, can it be prevented?
That's a good question. So, heart failure certainly develops over time, right? It's a condition over time that damages the heart, can cause a strain to the heart. Typically, things such as high blood pressure, blockages in the heart arteries, diabetes, smoking can contribute to that. Now, these are factors that are in our control somewhat, right? So, to answer the question, can heart failure be prevented? Yes, if we make these changes, right? Now, there's certainly some other causes of heart failure that we'll talk about soon in terms of genetic causes, amyloidosis, some things that are out of your hands. Right?
Yeah.
Some of the things that I highlighted before you can control, and that'll help prevent heart failure from developing.
Thank you. Well, we have some more questions, but before we get into those, I just want to say if you're just now joining us, thank you for tuning in. My name is Sarah, and I'm here today during Heart Month with a few of our cardiovascular experts. We're discussing how heart failure we're discussing heart failure and how it may be caused by a rare condition called cardiac amyloidosis. If you have questions, you can leave those in the comments below. Let's get back into our questions. So, Dr. Sheikh, what is amyloidosis? I struggle with that word.
Okay, thank you, Sarah. So amyloidosis refers to a disease where there is a misfolding of protein. And so if we think about how our body functions, there are billions of proteins produced in our body that do countless functions. Things we take for granted, like being able to see, is on the basis of the development of these molecules called proteins. Name it, a protein is involved. There are roughly 40 proteins known to human beings through science that results in amyloidosis, a disease where when the protein misfolds, it actually dissociates or separates. And when it separates, it creates these characteristic structures called fibrils. These fibrils act like cement in the body. Wherever they go, they stick to the organ. Classically, in cardiac amyloidosis, the proteins that cause it, it's usually the heart and the nerves. And when they stick to these organs, act like cement, they actually cause the organ to not function properly. The way we think about it in the heart and the way many of us use our phrase when we communicate to our patients and families, if you think of the heart as a brick and mortar structure, the bricks are heart muscle cells. The mortar, the skeleton of the heart, is called the extracellular matrix or the interstitium, and amyloid builds up there. Now, about 95% of all cases of cardiac amyloidosis can come down to two proteins, even though there are, as I mentioned, more than 40 amyloidogenic proteins, meaning proteins that cause amyloid. And those two cardiac precursor proteins are AL, A for amyloid, L for light chain, a disease of the bone marrow where there are cells within the bone marrow called plasma cells that behave badly. And when they do that, they produce fragments of antibodies, these molecules that help fight invading organisms and other viruses, etc. And those become amyloid because these proteins misfold and create the amyloid fibrils. That is actually a relatively rare disease, maybe 3,000 to 5,000 new cases a year, but very serious. It's an emergency and has to be addressed. And I have no doubt we'll talk about that later. The other more common disease, probably what's brought us together today, is an increasing recognition of ATTR cardiomyopathy, or A for amyloid, TTR for transthyretin, otherwise known as prealbumin, a precursor protein produced mostly by our liver, which is a shuttling protein for vitamins and hormones. And what it does is, in this case, it looks like a four-leaf clover, and it dissociates and becomes these amyloid fibrils. And classically, this involves the heart and the nerves.
Okay. And so can amyloid buildup also affect the veins and arteries going to and from the heart?
So amyloid theoretically can go anywhere. Technically speaking, sitting here today, we lack the tools to properly image every part of the body to see where amyloid is deposited. So it's likely that amyloid is actually in a lot of places that we're not aware of. Thankfully, there are some tools that are being developed using PET imaging that will very soon allow us to actually image everywhere that amyloid is in the body. But of the rarer form of disease, so I mentioned AL amyloid, 3,000 to 5,000 new cases a year, 50% of those cases have cardiac involvement. That is more likely to get involved in the arteries and veins of, or the blood vessels of the body, other than ATTR-CM. And I think it depends on the patient, it depends on the circumstances. It is possible, but it's not a leading phenomenon with the disease.
Okay. And Dr. Vora, who is at risk of being diagnosed with cardiac amyloidosis? I'm struggling with my words today.
Okay. So cardiac amyloidosis, as was mentioned, is a systemic disease. So that means these proteins can affect not only the heart, but they can also be found in the nerves in your hands, nerves in the feet. They can also affect other organs like the kidneys, the liver. So patients who are at risk for being diagnosed with this are patients who may have symptoms of heart failure, but then also have features that we notice that affects their nerves, such as carpal tunnel syndrome, or they have a lot of numbness and tingling in their legs. Nowadays, because we do have a lot of advanced cardiac imaging, we are also picking up this diagnosis if anybody has a cardiac MRI for any reason, but it's still typically patients who are being evaluated for heart failure. The other patients who are at risk, and it's important to note, 3 to 4% of self-described Black patients are carriers of a gene that can increase the risk of developing cardiac amyloidosis, the transthyretin type. And so certainly any patient who has any features on their EKG or their echo that could raise suspicion would be at risk for being diagnosed with this.
Okay. And are there any prevention methods, any lifestyle things you can do?
So unfortunately, like Dr. Afari mentioned as well, this is a phenomenon that is beyond your control. So it's not really possible to prevent cardiac amyloidosis. That being said, I think lifestyle changes are always a good thing. They can always help mitigate the effect of the disease. And so things like Dr. Afari was talking about in terms of watching your fluid intake, watching how much salt you're taking, trying to be as active and getting good cardiovascular exercise, those are always going to be helpful in any disease that affects the heart.
Okay. Great, thank you. And Dr. K, what are some of the common symptoms and how do they overlap with heart failure symptoms?
So there's a huge overlap with kind of what we've described to look out for the symptoms of heart failure. With cardiac amyloidosis, I think the mainstay that all patients share is issues with fluid retention. So edema, shortness of breath from fluid in the lungs, weight gain, abdominal fullness, just from all of that fluid retention is both common in all variety types of heart failure and specifically with amyloidosis. When Dr. Sheikh was talking about the mechanism of amyloid, when we talk about these proteins getting in between all the heart muscle cells, warping the structure of the actual muscle, well, we know the heart is a pump and it can squeeze forward, but the other part that we don't think about is how the heart relaxes. A pump is no good if it can't fill correctly. And one of the first signs that's happening in amyloidosis, either AL or ATTR, is you're actually having the toxic effects of this protein within the muscle causing stiffness of that heart. And that leads to the patient retaining fluid. So leg swelling, abdominal fullness, shortness of breath, the things that we discussed about with heart failure are very common with amyloidosis. And the advice that Dr. Afari said about managing your fluid intake, appropriate use of diuretics, tends to be a bit of the mainstay therapy as far as symptom management when it comes to amyloid. Now, there can be other symptoms as amyloidosis is a systemic disease to look out for outside of cardiac symptoms. We know, especially with light chain amyloidosis, those proteins can deposit in multiple other areas other than the heart, even though the heart's most commonly involved. But looking for things like new skin rashes, a bit of discoloration around the eyes, difficulty swallowing, tongue swelling. Some of these things can be a sign of other amyloid deposition going on in the body. And if you're seeing that in addition to what we consider heart failure symptoms, that can be a sign of there might be a systemic process that raises our suspicion for amyloidosis.
Okay. And we discussed this with heart failure earlier, but what are some of the symptoms that are often overlooked or mistaken for other conditions? I'm sure they're probably similar to some of the heart failure ones.
There is, but I think the struggle with amyloidosis is that as it is a systemic disorder, and sometimes the cardiac manifestations can develop later on in the process, it's important to have a pattern recognition and look at some red flags that things develop to come to an earlier diagnosis. If we can't prevent this disease, an early diagnosis is key to actually providing benefit with the novel therapies that are on the market now that you can kind of see being advertised. So looking at, with amyloidosis, your symptoms can vary from what organ is involved. For example, with light chain amyloidosis, if your kidneys are involved, you may have, kidney disease. If your nerves are involved, you're going to have neuropathy or nerve pain. So looking at these symptoms as they developed, especially in conjunction with someone developing unexplained heart failure or an unexplained stiff heart, putting that together is what leads us as physicians to do the kind of detective work that's necessary to come to an accurate diagnosis of amyloidosis.
Yeah. And speaking of diagnosis, Dr. Afari, what are some of the tests a patient would go through for to get a diagnosis?
So yeah, I mean, you actually just heard quite a few. I think the first thing doctors typically do, as you realize, is we try to elicit or find out certain clues for cardiac amyloidosis. So don't be surprised. I tell my patients, right? Your doctor may ask you a lot of questions. That's what we're supposed to do. Help kind of narrow down exactly our suspicion, especially if we're suspecting that you may have amyloidosis. So questions such as, do you have any pain in your wrist, something like carpal tunnel syndrome, whether you have a history of that? Do you have a history of neuropathy, any numbness and tingling of any other parts of your body? Again, do you have heart failure symptoms? Are you feeling short of breath? Do you have those swelling? So we try to piece all of that part together just to, allow us to have that suspicion of whether or not you have amyloidosis. And then your doctor might also or will probably order some blood tests as well, right? So blood tests, urine tests. From a heart standpoint, we always get an EKG, and that's the way to look for your heart rhythm, just to make sure there's no abnormalities there. We always get an ultrasound of the heart and maybe even an MRI of the heart, again, just to look at the heart structure and the heart function also. Because Dr. K just mentioned, right? The heart pumping function can be affected, and also the heart can get stiff and relaxation can be affected as well. So all these tests allow us to look into that. And more specific tests, as we'll probably hear about some more certain scans to really look for these proteins in the heart. Okay. You've heard us kind of throw out there the AL type of amyloidosis. So this is the light chain type of amyloidosis. In this situation, your doctor might actually ask for a biopsy. And if the suspicion is that the heart is affected, then that would be a heart biopsy. Okay. And of course, you'll hear this a little bit, and I think Dr. Vora actually mentioned it, that there is certainly a percentage of patients who have a genetic variant, predominant really in Black people. About 3 to 4% of Black people in the U.S. population do have this gene for amyloidosis. So genetic testing is certainly a part of the diagnostic process as well.
Yeah. And I think we touched on this a little bit earlier, but to go over it again, does amyloidosis, if undiagnosed, can it lead to more serious health problems?
Yes, amyloidosis can certainly lead to a more serious heart problem if it's not diagnosed early or treated early. Now, these abnormal proteins, as we've spoken about, they do stick to the heart muscle, right? They make the heart stiff, and ultimately they can actually make the heart too weak to even function and squeeze and pump blood out of the heart. Now, if the heart can't function, you can imagine you don't get enough blood flow to the rest of the body, right? This is when we usually call it advanced stage heart failure. As the heart muscle is getting affected, this affects the electrical system of the heart also. So a lot of patients might experience palpitations or irregular heart rhythm, on that EKG when the cardiologist gets that. Okay. So this is really an important reason why we need to be really more aware of this disease.
Okay, thank you. And Dr. Sheikh, will medication cure cardiac amyloidosis?
Well, Sarah, thank you for the question. I really appreciate this. So it's such an exciting question to imagine a day and a time where we might be able to cure it. The answer currently is we cannot cure amyloidosis, but as you're going to hear in a subsequent questions that you're going to be asking, I believe, Dr. Kadakkal, it is just a golden period in the history of the field of cardiac amyloidosis diagnosis and treatment. Whether we are speaking about AL amyloidosis or ATTR-CM, in either case, we are seeing revolutionary changes in the diagnosis, evaluation, and treatment of the disease. MedStar Health is well poised to address all of this. We currently have 3 FDA-approved treatments for cardiac amyloidosis, and we have clinical trials looking at strategies to prevent cardiac amyloidosis. So And MedStar Health is participating in that clinical trial. We have clinical trials that are looking at ways to digest amyloid from the heart, where it is embedded within the heart, to see if we can remove amyloid. That's another trial that MedStar Health is involved in. And what we know now is survival has never been better, and quality of life changes never more favorable than the current era. And you're going to learn more about this from Dr. Kadakkal and our colleagues.
Oh, I love that. That's great to hear. And yes, yeah, we'll get into the treatment options in a second. But real quick, Dr. Vora, is heart failure treated differently when amyloidosis is the cause? And if so, how?
So there are certainly overlaps because a lot of the manifestations of amyloidosis are heart failure and the fluid retention. So the similarities are you will be treated with diuretics to help with fluid management. The other things that are different, though, with amyloid is some of those guideline-directed medical therapy that we talked about earlier that are approved and recommended for all patients with heart failure. Some of those aren't as well tolerated in patients with amyloidosis because they may lower the blood pressure too much. And so we use a little bit more caution when using those medications. And then I think just what has been alluded to so far, it's such an exciting time in amyloid. So in addition to just treating the symptom of fluid retention, we now have therapies that can directly target the proteins depending on the type of amyloid. So that's certainly a difference in the treatments.
Okay. Thank you. And yeah, let's get into a little bit more into some of that. Yeah, we actually had a question from one of our viewers, Diana, who wanted to know if there was any meds for ATTR. So Dr. K, can you go over the treatment options that are currently available?
Yes, of course. It's truly an exciting time as we now have actual disease-modifying therapy in addition to the normal treatment that we would do for anyone with heart failure syndrome. So as Dr. Sheikh mentioned, there are now 3 FDA-approved medications for ATTR amyloid that actually focus on the underlying cause. So not just managing symptoms with fluid retention or managing someone's blood pressure or arrhythmias, actually attacking the underlying cause, which is this protein depositing into the heart muscle. And so we have oral medications that are essentially work as protein stabilizers. We have a medication called tafamidis. We have another medication called acoramidis. These are pills that you can take that will bind the protein, the TTR protein that's made by the liver, stabilizing it and therefore preventing it from depositing into the heart muscle. We also have additional medications. We have subcutaneous injection medications that work through a different pathway that actually knock down production of the protein. So in addition to oral pills that can actually stabilize the protein, we now have medications that you can inject in clinic 4 times a year, so every 3 months, that essentially will get into the liver cell and prevent the TTR protein being made, therefore halting or at the very least slowing progression of the disease.
Okay. Thank you for going over that. I feel like I'm in biology class again, learning about all this stuff. So Dr. Afari, once on a treatment plan, can life expectancy improve or return closer to projected life expectancy?
Yeah, I mean that's a very important question. The answer really is yes, and in many cases, the life expectancy can improve significantly with appropriate treatment. But whether or not that returns to a normal projected life expectancy usually depends on the type of amyloidosis, right? And how advanced it is at the time of diagnosis. So imagine, essentially how much damage the heart's gone through before it's diagnosed. And of course, how you respond to treatment. So all of this really emphasizes the importance, right? Early recognition, early diagnosis, getting on treatment earlier. Because the earlier you're on treatment, certainly the closer you can be to survival with the medication.
Okay, great. Thank you. And Dr. Sheikh, how often should blood work or imaging be done to monitor if the medication is working or not?
Yeah, thank you very much, Sarah, for the question. This is actually a work in progress for us to develop as a center of excellence for the comprehensive care of amyloidosis patients, which, we're very proud of the fact that we can provide this care throughout the boundaries of MedStar Health, all the way to the north, to the west, to the south, and the east. Really, what we have to do is, one, get an understanding of the severity of illness at the time of diagnosis. Like other diseases, such as cancer, there is actually a staging system for ATTR-CM as well as AL amyloidosis. Remember, these are together, these two precursor proteins make up more than 95% of all cardiac amyloidosis. There are some other rare diseases that go beyond the scope of today's discussion, but we employ those staging systems and scores to guide us as to the frequency of visits and what lab testing needs to be performed. As to whether disease-modifying treatment and other interventions, when employed, improve the outcome of patients, it is very much patient-specific. I would say on average, our interface with our patients is every 3 months. When we engage with our patients on that quarterly basis, we typically draw blood tests to assess how patients are responding to the treatments. That includes imaging, that includes functional capacity assessment. The best predictor of human success in regards to longevity and survival is functional capacity. And so we do testing in clinic known as the 6-minute hall walk or 6-minute walk test, which provides us guidance. And that is a test that every center that focuses on cardiac amyloidosis uses to provide some prognostic insight as to how a patient is doing.
Okay, thank you. And Dr. Vora, we talked a little bit already about lifestyle changes that can be made after. So is there anything else, like would sleeping flat on the back versus your side make a difference, or being cautious of using any over-the-counter medicines? Anything else that would be a concern for someone with amyloidosis?
I think it's important that you ask about over-the-counter medications. That's a very good question, and it comes up a lot. And so I think in general, before you take any medication over the counter, you should definitely check with your amyloid provider, cardiologist. But just good rules to avoid medicines that are called NSAIDs. So those are things like ibuprofen, Advil, Motrin, naproxen, Aleve. Those can actually be pretty harmful in cardiac amyloidosis. So those can worsen signs of heart failure. They can also increase risk for bleeding. So those are important to avoid. And then decongestion, certain ones used for cold. So anything with Sudafed or phenylephrine in it, with the letter D is usually not a good medication for somebody with heart failure. And then there's also some medications called antihistamines like Benadryl, which can lower the blood pressure a little bit too much. So it's just always important to be cautious about the over-the-counter medications. In general, Tylenol tends to be safe. And some of the cold medications, if they are approved for other patients with high blood pressure, you can ask the pharmacist or ask your daughter, or your doctor. Those are reasonable to use.
Okay. Thank you for going over that. Yeah, that's important to know. And Dr. K, we already, I think, touched on this a little bit too, but important to go over. Is amyloidosis genetic? And if so, are there steps that family members or children can take to reduce those risks?
Yeah, you're absolutely right. I think Dr. Vora had mentioned that when it comes to ATTR cardiac amyloidosis, there is a subtype that is genetic. And there are a variety of genetic mutations that are associated with this, one of which was very prevalent in our country among our Black or African American population. Now, I think it's important to note that even if you have this gene, it is not fatalistic or 100% certain that you will develop the disease. There's still a lot we don't know about how certain genetic cardiomyopathies, and even when it comes to amyloidosis, how they actually manifest as we age. But your risk is higher. So if you are a carrier, it's important that you have that proactive information, because it opens you up to actually having routine clinical screening. Periodic visits with a heart failure specialist to actually have cardiac imaging to look for any manifestation of the disease, any structural changes in the heart, any new symptoms that may have developed, however subtle, for an earlier diagnosis that would then warrant a better outcome with earlier treatment. We do recommend that those of us that have been diagnosed with the genetic type of amyloidosis, that they do discuss with their family and work with our genetics counselor for genetic screening and seeing if they're open to it. If they're not, we do recommend clinical screening. And for those that are actually carriers, even if they're healthy and if they don't have any manifestation of the disease, we do check in with them every 6 months or yearly to do that clinical screening, as they are at higher risk of developing the disease as they age.
Okay. Thank you for that. And we have a question from one of our viewers. Michael asked, does polyneuropathy symptoms of amyloidosis rule out the possibility of heart issues?
So having neuropathy or nerve involvement can actually coincide with cardiac. We actually think of ATTR amyloid almost existing on a spectrum, which anyone can actually fall in any type, anywhere in that spectrum of having more neurological manifestations or more cardiac manifestations. But just having nerve involvement does not mean that it's not possible to have cardiac involvement. And it's one of those hallmarks that if we see someone having any type of heart failure symptoms or having that kind of red flag of early onset neuropathy that we can't explain, we will go chasing and we'll go prove to ourselves that the heart is not involved.
Okay, thank you. And thank you for your question. My last question, I'll start with you, Dr. Afari. I'll ask it to you, but if anybody else wants to chime in, feel free to. What advice would you give to someone who may be experiencing heart failure symptoms but does not yet have a diagnosis, or someone who has recently been diagnosed with heart failure or cardiac amyloidosis?
Yeah, I mean, I think for the first part, for anyone who's obviously experiencing any heart failure symptoms, the most important advice I can give you is really don't ignore it, right? Don't self-diagnose. See your doctor immediately, get evaluated, and I will actually advocate a lot of people to really seek to see a heart failure specialist, right? A doctor who really deals with this type of disease. Now, if you are someone who carries a diagnosis of heart failure or cardiac amyloidosis, I get it. I mean, it's such a diagnosis can be quite overwhelming, really. I mean, it's important to just know that many patients live with that disease, and it's just important that you have proper early treatment and monitoring.
Great, thank you. All right, well, that's all the time we have for today. Thank you all again for joining us and taking time to share your expertise. And thank you to our viewers for tuning in. We hope this was valuable to you. And if you learned something today, please be sure to share this video and tag someone in your life who may also benefit from watching this. For more information or to schedule an appointment, you can visit the link that we'll be posting in our comments, or you can call 410-248-8465. We'll be posting that number in the comments as well. Thank you all again for joining, and we will see you next time.
Thank you.
Thank you.
Thank you.
Thank you.